Hello, my name is Suzanne Egan and I work at the University of Sydney in Australia. And I want to begin this presentation by acknowledging that I'm giving this paper on the unceded land of the Gadigal people of the Eora Nation, and to pay my respects to elders past, present and emerging. I'm interested in the concept of trauma, a concept which, particularly in its current form, is very much associated with medicine, psychiatry, and increasingly neuroscience. And I'm interested in how this concept has been used in applied, or is being used in applied feminist work against sexual violence. The ideas I'm going to explore today are grounded in research I conducted in the Australian Sexual Assault Services sector, and also to some extent by my previous work as a counsellor in those services. And as the title suggests, my paper is going to focus on the ways in which sexual assault workers use their understanding of trauma, and in particular neurobiology of trauma, in ways that are enabling rather than disabling or pathologising, and which are considered not only compatible with but an integral part of their feminist practice. And I'm particularly interested in the possibilities that this way of engaging with trauma and neurobiology has for feminist theoretical work on sexual violence. What I'm going to do first is give some brief contextual information about the sexual assault services sector in Australia, about what I mean by the term trauma, and a synopsis of the types of concerns raised in the body of feminist scholarship that I'm engaging with. Okay, given that service provision in Australia is a state rather than federal government responsibility, there's some variation between states and territories. But generally, it's basically a combination of government and non-government services. For example, in New South Wales, where I conducted my research, there's a network of around 70 government sexual assault services that are based in community health centres and hospitals, a network of NGO sexual assault centres, as well as Rape and Domestic Violence Services Australia, which is a quite large NGO that began initially in the early 1970s as one of Australia's first rape crisis centres. Most services are involved in community education and prevention work, as well as individual counselling and crisis work. And I think it's probably fair to say that it's the counselling and crisis work that's really considered their core work. It's also considered quite specialised or professionalised area of work, with counsellors typically or really required to have at least an undergraduate university degree. Almost half the counsellors I interviewed had some level of postgraduate qualification as well. And it's typically not an area that new graduates find employment in. So generally people will come in to that field of work after they've had at least a minimum generally of 2 years counselling experience in a related field. It's also a sector in which trauma has been increasingly prominent, particularly in the types of professional development training, workshops and seminars that's provided by various training organisations. The concept of psychological trauma in its most general sense rests on the premise that while some adverse experiences, sexual assault for example, may not result in physical injury, they can have profoundly injurious psychological and emotional effects that are often not as readily visible as physical trauma to the body, a broken bone or an open wound. In more formal terms, psychological trauma has been recognised since 1980 as post-traumatic stress disorder, or PTSD, a psychiatric diagnosis with a specific set of symptoms or effects effects and attentive diagnostic criteria. And I guess a shorthand way of talking about those effects is to say that often the person will cycle between being and feeling overwhelmed or flooded with distressing memories, nightmares, flashbacks, sensations or images of the abuse, and shutting down and becoming quite emotionally numb as a way to try and cope with and stop the overwhelm. And often people will be quite hyper alert or hyper vigilant, a sort of sense of always being on guard and a heightened level of physiological arousal, particularly around and anything that reminds or triggers memories of the abuse. Increasingly, understandings of trauma and traumatic reactions are informed, whether implicitly or explicitly, by neuroscience. And as an example of that would be the idea that traumatic memory is encoded in different parts of the brain to normal memory, and that because of this it's often recalled in sensory form as images, sounds, smells, rather than cognitive form as a verbal narrative. Complex trauma, or complex PTSD, as the name suggests, denotes a more complex and diffuse set of effects associated with ongoing and repeated abuse, particularly though not always the child sexual abuse perpetrated on children. And it's a term that was first coined by the American feminist and psychiatrist Judith Herman in her influential text Trauma and Recovery, although it's been taken up by others since then. And while it's not included in DSM, the Diagnostic Manual of the American Psychiatric Association, as a distinctive diagnosis, it's typically referred to as a clinically recognised condition, and that's both in the types of literature and resources that workers within the sexual assault services draw on, and by the workers themselves. Although complex PTSD has recently been included in the International Classification of Diseases, the ICD, used by the World Health Organization. Okay, so some of the feminist debates and concerns and critique about trauma. So internationally, at least, internationally, at least with Anglo-American feminist scholarship, the uptake of what Maracek has referred to as trauma talk in feminist work has been a source of concern and some fairly sustained critique. And while there are nuanced arguments, they tend to be grouped around the following concerns. Firstly, that trauma discourse individualises the issue of sexual violence, reducing a social and political problem or issue to one of mental health and individual adjustment. For example, Burstow, amongst others, argues that the adoption of diagnostic categories and symptomology pathologises survivors by treating the effects of sexual violence as deficits to be fixed. And there's often an underlying concern, sometimes explicitly expressed, other times implicitly referred to, about the incursion of medicine and psychiatry that those types of diagnostic criteria represent. So, for example, some feminist scholars, Levitt and Whittier, for example, distinguish between the metaphorical use of trauma to denote injury to the psyche used by some feminists during the 1970s and 80s, and the formalised contemporary trauma diagnoses, categories and models. And related to these concerns that I've just outlined is that the uptake of trauma in feminist counselling and within the sexual assault services sector, and also domestic violence work, is often understood as symptomatic of a decline in feminism as a social and political movement. And my work, as I've said, is in part a dialogue with those critiques and concerns. And what I'm aiming to do is provide an alternative, or introduce an alternative into the conversation by showing what trauma can look like and the enabling ways it can be put to work in what Mackenzie and Roberts have referred to in a related area as the messy context of real-world practices. Which is not to say that I'm trying to argue that there's no problematic aspects of the uptake of trauma, or that it may not be used to individualise. Only that that's by no means inevitable in my view. And I want to talk about the uptake of neurobiological understandings of trauma, because this was the knowledge that I thought, or I found, that sexual assault counsellors were actively mobilising as part of their established feminist practices of empowering, advocating for survivors. And because it was where they most explicitly identified a gap in terms of what feminism had been able to provide them in the day-to-day realities of their work. Okay, so I'm going to look now, talk about what trauma looks like in practice. I'm just going to start with what I think of as the field speaking back about what practitioners saw as some of the limitations of feminism. So these practitioners had been well schooled in feminism, often through the university studies, some through activism, and others, particularly women who'd worked in the sector for many years. I talked to at least 2, 3, maybe more, who had been there almost from the inception, or getting on towards 15 years and above. So for those workers, it would be more of an on-the-job training into the values, ethics and practices of feminism. And working in a sexual assault services was, as one of my participants said, a place where it was very easy to be a feminist. And that was certainly my experience when I first began counselling work in that field in the late 1990s, and also more recently having spent time as a researcher in a non-government rape crisis centre. And yet, for these workers, there was also not always expressed dissatisfaction, but more of a pointing out that while feminism was absolutely integral to their practice and underpinned their, central to their understanding of the social and political causes of sexual violence, that this type of broad-based understanding, what one counsellor referred to in a slightly exasperated tone as the big public health approach to sexual violence, wasn't always terribly helpful at the coalface, so to speak. So it wasn't always terribly helpful in assisting them to know how to respond, for example, to a woman on the phone suffering distressing flashbacks or dissociating, or who may just be plain exhausted from lack of sleep. And that can often be the types of work that somebody is doing, particularly when they're doing 24-hour crisis telephone counselling work. And it was in those sorts of contexts that the practitioner's understanding of the neuroscience of trauma, of the way that trauma affects the body and the mind, proved most useful to them in responding to and trying to assist victims and survivors in these types of situations. Okay, so I'm going to, over the next 3 slides, show excerpts of how trauma was being used in an enabling way. And I've chosen the excerpts from the interviews because they represent a theme that was running through the data. And this first excerpt in particular I've chosen because it was typical of how trauma and traumatic memory was understood and spoken about across the interviews. So in this particular scenario, the practitioner's been talking about working with a woman who'd been subject to abuse for a number of years, such that her daily life was often interrupted by distressing flashbacks and nightmares to this abuse. So as this interview participant says, parts of the brain affected following a traumatic event are the imagery parts of the brain. The idea, as I mentioned earlier, that traumatic memories are stored or encoded differently to non-traumatic memory. And that because of this, images, sensations and bodily reactions and the attendant, physiological reactions, the increase in adrenaline, cortisol, increased heartbeat and blood pressure, can really make it feel to the person as if the trauma is happening all over again. And this is what Bessel van der Kolk has referred to as the body keeping the score. The way that trauma is remembered in the body and in the neurological and physiological responses, as much as via a narrative account or cognitive memories. So in this next excerpt, it's in a continuation of the one on the previous slide, the counsellor goes on to explain how she uses or harnesses this understanding of the brain and traumatic memory to help the woman she's working with to regain a sense of control over her reactions. So essentially working with her in counselling to be able to replace those negative images, the images and memories of the abuse, with a memory or experience of when she felt safe and secure. And the effect of this is not just an evocation of cognitive memory, but also of the feelings, emotions and sensations that goes with that memory. So I think in this particular instance, the client, the woman, had focused on a particular time she'd spent with her parents, I think at a beach where she felt very safe and secure. Maybe it was when they were on holidays, I can't quite recall. And so this counsellor explains that while this type of work begins in this case in a counselling environment, in a safe, controlled environment, the aim is that the person can use these types of strategies when they're going about their ordinary daily life. So overall, this type of work can play an important role and does play an important role in establishing a sense of psychological, emotional and physical safety. And the use of this type of knowledge about how the brain and the body responds to traumatic experiences was understood by practitioners as a way that they could assist the people that they work with to regain a sense of power and control that is often what's lost as a consequence of sexual violence. And in many ways, that was one of the key things that they identified as the compatibility between trauma and feminism, and why they considered it integral to their practice. Okay, this is going on to a different slide, but continuing on this, a different interview excerpt, but continuing on the same theme. And this practitioner has been talking about the crisis work. She's the manager of the sexual assault service. So what she does on the crisis, as part of the crisis counselling and the work that her team does. And I guess it's not surprising that this understanding of how trauma affects or can affect the way a person presents was highlighted as particularly important in crisis work. So as I said, this participant's a manager of quite a large service based in quite a large metropolitan hospital, and she's talking about her work in coordinating the 24-hour crisis counselling and medical response. And while crisis work involves many things, one of the typical situations is when somebody comes into a hospital very soon after being assaulted, often, not always, but often accompanied by police. And one of the issues that will be broached by the counsellor is the possibility of a medical examination for both health and forensic purposes. So as this sexual assault manager is pointing out, this understanding of trauma is particularly important in these type of scenario, because it gives an understanding of why the person may not be able to, or may struggle to, give a coherent verbal account of what's happened. So to understand that they may recall things in a very fragmentary way, that there may be quite acute detail of, what could seem to be a fairly minor detail, a pattern of a bedspread, a particular smell, or a sound, but that is the way that traumatic memory is recalled, and it helps the counsellors and also the other professionals that they are liaising with, police, medical practitioners, to understand why the person may not be able to, or may struggle to, give a chronological account of what's happened to them. And also to understand that while one person may be highly and visibly distressed, another may appear quite detached, almost cut off, or preternaturally calm. Okay, so I want to now move on to speak to what I see as a level of reflexivity that was demonstrated through the interview text, and knowing rather than an unknowing uptake of trauma. And I think that's important because, at least in some of the feminist literature, there's almost a sense or an understanding that counsellors, practitioners have been co-opted or duped somehow into using this, what Marichak fairly critically refers to as trauma talk. And I've chosen this particular excerpt because it brings together a number of themes that run through the practitioner's response. So I'm going to read it in full, and then I'll make some comments on it. So she starts by saying, and I suppose I was thinking, also, we used to be very afraid of pathologising sexual assault. And then the interviewer, who is me, says, in what sorts of ways? And the practitioner says, well, I suppose the medical model of victims are victims, and sexual assault leaves them incapacitated, I suppose. I think with this neurobiology stuff, it does recognise that there is some real harm that's happened to someone, to their bodies, to their beings. But it's important not to buy into that as well, because people also have agency, and they always have capacity to recuperate and to do things that help them as well. And so then I go on to ask them how they manage that within the feminist framework, how they manage the balance between the feminist framework and drawing on trauma. And she says, well, I just see that if a person is traumatised, then it's not necessarily something that is about harm, bodily harm, and it's something that has to be healed in a way. And that's very possible, but it doesn't leave the person, like the patient, without any control and being acted on. So I found that quite a powerful statement, and it did, as I said, sum up some of the key points that practitioners reflected on. The first being this fear of pathologising sexual assault and absolutely not wanting to do that. And, you know, one of the, another worker I spoke to had said, reflecting on the uptake of trauma, which people were quite aware of, it was identified as one of the big, you know, significant changes over time in this field of practice. And she said, you know, we were just, you know, in early years, there is absolutely no way that we would have drawn on work of psychiatrists, in particular male psychiatrists, at least in, you know, some cases, a lot of cases, because this, you know, the medical and feminist work were seen as very oppositional and at polar opposites. And so there was this I guess, a degree of caution and discernment and very much an awareness of not wanting to individualise, not wanting to pathologise, but finding this body of knowledge very useful to their work. What was the other points that I wanted to make?